Hi Raju, how are you doing today?
Good, Michael, and it's great to see you after such an extended Christmas and New Year break. Let me start this short podcast by presenting you a simple case scenario in your practice. You have a child with polyarticular GI. This child is on Etanercept, and you have to discontinue this drug either because the child is not responding or is showing adverse effects. What drug would you change
Yes, Raju,
to?
this is a question, but still a challenge to know which drug we should use in a patient not responding or no more responding to etanercept. And here there are two different views on different sides of the Atlantic. From the ICR recommendation, we learn that we have to use another type of drug like rituximab or tocilizumab or JAK inhibitor. But in Europe, based on the EULA recommendation, we would rather start with another anti-TNF, and usually it's adalimumab, what we will use for.
And indeed, Michael, the paper we are going to be highlighting today from the ACR journal attempts to throw clarity on exactly this issue.
Yes, and it's interesting because these are data from registries. First, the CARA registry, where they did a retrospective analysis of the data from 2015 to 2020. And simultaneously, they compiled a previously published study from the UK registry, but using the data differently. And what is interesting is that the ACR recommendation I was referring to were published in 2019, so in the middle of the study. So the majority of the patients in the study we are discussing from this paper were treated with a second anti-TNF.
Yeah, and they stopped the study, fortunately, just before COVID started, and therefore they had a physical follow up of these patients. Notably, Michael, inclusion was very strict in observing the criteria, and these had to be two visits 6 months apart and excluded patients who had
And this is right,
uveitis.
Raju, because we usually do not use etanercept for uveitis patients because we know that TNF antibodies are working much better.
Right. And what they did was they used CJADAS 10 with a score of less than 2.5 to define inactive disease and less than 5 to define minimally active
Okay, Raju,
disease.
but what did they find in summary?
This is interesting, Michael, because their final conclusion is that shifting from one TNF to another is equivalent to using a non TNF agent when it intercepts.
But here there is potentially a bias because the majority of the patients treated with etanercept were then treated with a second TNF inhibitor. But I think the authors took care of this problem. Nevertheless, this study was, I think, very interesting for us on the practical aspect to help us in the choice of a second biological agent. But Raju, in your setting
Yes,
in resource challenged countries, what is the practical what you take from this study?
Michael, this is most relevant. Let's understand that first of all, we do realize that, as I have said in previous podcasts, IL-1 inhibitors are not available, and drugs like rituximab or tocilizumab are much more expensive than adalimumab and need at least half a day of, or perhaps a day care of hospital stay for the infusion. So now, with this paper, I'm going to confidently consider adalimumab, though it's slightly more expensive as compared to etanercept, but very confidently with some evidence as a replacement to etanercept.
But you see, Raju, this is very interesting because we are 25 years after the introduction of TNF inhibitors and especially etanercept in the treatment of polyarticular GIA, and there are still a lot of open questions how we continue with the treatment, how we win, or how we stop the treatment. So we are in evidence-based medicine, but in rare disease, it's sometimes very limited. And practical experience of the colleagues is very important.
True, Michael, learning never
Thank you, Raju.
stops.
Bye bye.